Alright guys, last but not least, lumbar spine, sacrum coccyx, SI joints, and Scoliosis Series. You see this is a good technique chart. I'm going to be referring to this throughout the video. Make a small version of this, put it in your notebooks. Alright guys, let's get into lumbar spine. So we got two views for our standard protocol. It's going to be an AP and a lateral. We do them on the table for our standard procedure. We're going to start with the AP. We have L5 here, 4, 3, 2, and 1. You can see T12 right up here with the ribs coming off the back, sacrum at the bottom. Collimation is going to be to the SI joint. If you have those both fully in your picture, you know you got great collimation. When you start to clip these off, it's grounds for a repeat.
And when you have your patient on the table, you want to make sure that you double up their pillow and you bend their knees so the feet are flat. What that's going to do is flatten out this lumbar spine, put the vertebral bodies in profile, and also the sacrum will flatten out and get a much better view of it in our picture.
So let's get into the position.
So one more thing to keep in mind with your APs, just watch for rotation. Double check that your spinous processes are right down the middle here and your SI joints are equidistant. It's going to help you determine if you need to repeat or not. Now, moving on to the lateral, same idea. We want to make sure we have all 5 vertebrae in the picture. So 5, 4, 3, 2, 1. We want looking for the intervertebral foramen. You see them nice and in profile. The bodies of the spine aren't overlapping on themselves. Perfectly in profile. This is a great lateral. Alright, so some common errors I see a lot is over-rotation on our lateral. And you can see here the ASIS of the upside is much more anterior than this downside ASIS. You can tell this is the upside because of the magnification here. So this tells me that this patient is over-rotated. And a lot of patients do that because it's painful to put their greater trochanter down on that hard table that we have. So a lot of patients are going to put themselves into this specific position thinking that they're completely lateral. So just be aware of that. Always roll your patient back slightly when you think they're lateral. When it comes to the AP, you can see a rotated version here. The ilium on this right side is much more opened. It's foreshortened on the left side. See rotation in the pelvis. And that would make for a repeatable image.
Alright, so here's where it gets a little tricky. If the patient has a scoliosis of any kind, you have to determine which lateral you're going to do based off of that. Alright, so here you see the scoli goes down, cuts over to the right side of the body, and then comes back to the midline here. Okay, in this scenario, we're going to be doing a right lateral because the way the divergent beam works, going through
the spines this way, you're going to get a much clearer picture of those joint spaces. Okay, if you were trying to shoot through this way, the bodies of the spine are going to get in the way of each other, and there's going to be a lot of overlap. So if the spine was coming down headed this direction and then coming back towards the midline, that's going to be your standard left lateral.
All right, let's get into some special views that we do only when the ordering provider puts it on the rec. Okay, we'll start with the L5-S1 spot film, and you can see here nicely coned into L5 and S1, and we're going to angle down caudally 5 degrees from where we started on our lateral L spine. So if you have a good central ray on that, you angle down 5 degrees, you're going to get this every single time. Okay, and then for the obliques, we're going to angle our patient up 45 degrees. You see how foreshortened this ilium is compared to the other one. And we're going to see these Scotty dogs. Okay, you must see the Scotty dogs on your obliques in order for it to be a good one. If you don't see those, you got to repeat it. And the hardest part about this is going to be able to judge your central ray. Sometimes doctors are going to order flexion and extension views. Now these are going to be specified on the requisition, not part of our standard procedure. But what is standard is when we do this, we're going to be doing it in the sitting position. So keep that in mind when you're taking these. Always sit your patient down in either a stool or a chair without handlebars. So here's some problems you're going to run into with flexion and extension, and most of it's going to have to do with your technique. Okay, if you set a technique, you have to use a lot because you have all this abdomen here. You're going to keep your cones a little bit more open on this flexion especially. This abdomen is going to attenuate a lot of that. You're going to lead to an underexposure a lot of the time. So just be careful of that. If you're going to use AEC, make sure you're centered right over that cell and everything. The distance is in at 40, not at 72. All right, so moving on to cross-table imaging. This is going to be done whenever the patient is in a trauma situation or they can't roll up onto their side. You can see they did this one still in the stretcher. The railing is showing up as an artifact. And it's very important when you're doing these to keep them on a slide board or a pad or something to suspend them up above the table or the stretcher, whatever it might be. Okay, so if you do the AP on the table and use the slide board to bring them there, keep them on that slide board when you get them back onto the stretcher. It's going to help you center much easier to this lumbar spine. And with any cross table imaging, central ray is very, very important. All right, so moving on to sacrum, we have to angle our tube 15 degrees cephalic. Do not forget. Okay, and what that's doing is putting our sacrum in profile. Naturally, it sits about 15 degrees posteriorly to the body. So by angling up 15 degrees, we're going to put this nice and perpendicular to our beam. Okay, and the goal is to get the sacral base right at the bottom by the pubic symphysis. Here's a good example of too much angle cephalically. And you see here the pubic symphysis is halfway up the sacrum there. Okay, this is actually an inlet view of the pelvis, a completely different view, but it's a good example of sometimes when the patient's butt is kind of up off the table a little bit, and then you angle up 15 degrees on top of it, the pubic symphysis is going to be up way too high and obstructing half of your sacrum there. So if this is a sacrum image, you need to repeat this. If this is an inlet view of the pelvis, it's perfect. Congratulations. Now look at this beautiful Coccyx x-ray. That's some tight collimation, but you can afford to do that because it's the same central ray as your sacrum. So if you had a good central ray on that, use your marker to determine what your central ray is going to be for your Coccyx x-ray. The one thing you can't forget to do is now you have to angle caudal by 10 degrees. Okay, so do not forget to change the tube angle when you do this. For the lateral sacrum Coccyx, all we need is to see L5 up top, make sure we have all the Coccyx down below, and you can use the ischial spine as a reference point to make sure you're not rotated, okay? You see a tiny bit of overlap right there, but not nearly enough for a repeat, okay? But use these, make sure they're right on top of each other. That's how you know you got a good lateral. So moving on to SI joints, our protocol is to have no angle on the tube. Okay, you're going to see a lot about putting a 20-degree cephalic angle in your textbooks, but our protocol here at the hospital is going to be a perpendicular beam straight down, centering at the ASIS. And when you do obliques, it's not quite a 45-degree angle up. Use your sponge and get your patient about 20 to 30 degrees. That's going to get you a good view of these SI joints. And last but not least, we have the Scoliosis Series. So a few things to keep in mind with this. You have to take off the patient's shoes before taking this exam. Shoes can sort of compensate for people's scoliosis, so we want to take those off and get a true visual of what that scoliosis is looking like. And we're going to do two views, AP and a lateral. Keep in mind we want the top of the ear attachment all the way down to the pubic symphysis